Thank you for that warm introduction. And if I'm even a half excellent surgeon, it's because of Dr. Grover and my mentor, Dr. Roshmi, both of whom are here today. So I'll be talking about what can go wrong in an anophthalmic socket. Before that, what is the ideal socket? So there should be a satisfactory central implant, a healthy epithelium, adequate volume, and a good phonics so that you can have a good prosthesis inside, and normal eyelids. So this is what we would constitute as a ideal patient with an ideal implant and phonesis, preferably with a good amount of motility. So some of the types of prostheses we have are the custom made prostheses, the stock eyes, spectacle mounted, and stick on silicone prostheses. In a congenital socket, you may have congenital anophthalmia. So, Dr. Jayanta will be covering this in more detail, but the concerns are basically the shrunken bony orbit, minified eyelids, and deficient conjunctiva, which can retard the half of the face also from developing. The workup includes a good ultrasound and possibly an MRI along with a multidisciplinary approach, more importantly, with that of a good ocularist. The factors which are assessed, not only the bony hypoplasia, also the soft tissue hypoplasia, as well as the lid and orbital cysts which can form. So expansion is done with respect to the orbital volume with spheres, expanders, grafts, etc. Post-operative inflammation. So immediately after you do a surgery, like an evisceration, you may have post-operative inflammation. So it's important that you give a good amount of oral steroids after the surgery. You can have dryness in the socket, discharge, and irritation. Irritation could be because of development of papillae, giant papillae. Enophthalmos is another issue. So it could be without a primary implant or with a primary implant, wherein the implant may have migrated or it may not be of adequate size, may require to be changed. You can have a superior sulcus deformity because of decreased orbital volume. This can sometimes be treated by putting in fillers or even changing the implant. You can treat these conservatively along and also with surgery. Implant exposure is another issue. It could be early because of inadequate closure or because of an infection which develops, or a late cause like because of fibrosis or pressure atrophy because of the tissues which overlie the implant. So this is how that would look. These can be again treated conservatively or with a patch graft or a secondary implant. Now, the inferior phonic shelving, this makes sure that your prosthesis doesn't sit well. So the inability to retain prosthesis is a big issue in a anophthalmic socket which can develop, and this has to be treated with respect to the phonics formation, increasing the surface. You can have ptosis. So it can be mild, which can be treated with the prosthesis modification, again relying on your ocularist, or you can have severe ptosis which requires surgery. Implant migration, you can treat this either by filling the rest of the areas with a filler or sort of making the implant come centrally with other procedures. And the other thing is the contracted socket, which can be mild, moderate, or severe. This can be because of loss of tenons, inadequate dissection at the primary surgery, or late causes because of multiple repeated surgery, which is a common cause. So prevention of this is preservation of conjunctiva, minimizing dissection in the phonesis, limiting cautery, and of course wearing a conformer. So if they don't wear the conformer or if they remove it for a long period of time, that can also cause a contracted socket. So you evaluate it with the eyelid position, the socket lining, how the prosthesis is sitting, the state of the prosthesis itself. And you look at other issues which can happen in the socket, that is fibrous bands, symblifera, ptosis, entropion, ectropion. These procedures will be covered by the subsequent speakers, so I won't be going into that. Moderate contracture can be treated with a mucous membrane graft or amniotic membrane graft, also a dermis fat graft which gives volume as well as surface. And severe contracture, could be a dry or a wet socket, so the treatment would depend accordingly. And you can have an epithelial lined socket like this, which is an epidermal graft. You can have severe cicatrization. So this reconstruction also requires a lengthy process. This will also be covered. Granulomas can be excised. Symblifera can be treated with grafts. Cysts, you can either use bleomycin or a fibrin sealant to excise, or you go ahead and excise the cyst itself. You can have lid malpositions, which will also be covered, and anophthalmic ectropion. Of course, the excentrated socket has its own set of issues. There may be inadequate coverage. You can have loss of tissue there, which would lead inside the orbit. So this also has to be treated. For this, you can use reconstruction by taking the help of grafts in and around the face. You can have persistent failure of surgery. Even after you try everything, you're not able to manage. You can use tinted lenses, you can use spectacle mounted prostheses, and now our ocularists have come up with this prosthesis which has the mirrored image of the other eye as well. You can have infections in and around the socket. There can be syndromic issues. So it's important that when you have an atrophic bulbi, you do the adequate type of surgery so as to give the best possible volume. And this is a summary of all the issues which I've discussed just now. And each of these will be covered in detail going forward. Thank you.